This is the video about the work with 4 anterior teeth, to be more precise, the work with the teeth and implants. My subscribers in Instagram could have seen the initial situation. It was quite comically awful. There was not even a bridge there. There was some kind of 4 crooked straight restorations that were caulked inside with a glass ionomer. In the first appointment I made from this the normal temporary bridge. We endodontically treated these teeth, we restored them, I prepped them, I remade the temporary bridge. Right now the time has come to create for this patient single temporary restorations on implants and teeth. These are Astrotech implants that are placed at the same clinic in the Netherlands, and they're placed not so good, so and so. And you see in the position of the tooth 2-1 there was an attempt of the soft tissue grafting. To my opinion, it's unsuccessful. Implant in the position of the tooth 1-2 is not deep enough. We'll work with what we have. The attempt to try to extract the Astrotech implants in the position of the anterior teeth is a catastrophe. And on this appointment I'm making an impression for the creation, for the production of the temporary single restorations. Right now I'm placing the cord 3-0. You'll see the apical displacement of the gingival margin, and I will also displace the finish line in an apical direction. It's quite strange, but the patient is ready for everything. She was compliant even with this ugly, awful temporary bridge. But if we would show it to you, it's not, it's not even funny. It's gloom. It's not even the style of the state-funded clinic. It's much worse. Quite willingly we can place the 3-0 cord. The tooth 2-2 was rotated. That's evident from this straight position of the gingival zenith. I propose to the patient to repeat this rotation of the tooth. That is in line with European style of dentistry, but she told me, no, you made a bridge for me. In general I like it, so let's keep it in that way. I said okay, let's try to align the tooth a little bit more with a diamond burr. Of course there is a malocclusion here, there was a big overjet, the teeth are in protrusion of the upper jaw, but right now the orthodontic treatment is contraindicated. First of all, because many teeth are missing here, many teeth are severely damaged, not severely, but anyway they are damaged, and there are implants with it. This is the most problematic. If we'll start to move the teeth and the implants will stay in its initial position, for example, we'll correct the protrusion, but it will not lead to anything good. So we will work with what we have. Well, in the end, she doesn't have any complaints from the Team J. We have to treat her by segments, not to try to do everything in one go, and then the risk to have a mistake in occlusion will be minimal. It's a sure cord, the retraction cord 3-0. You know it very well. Good scissors. It's with its weight in gold. Good scissors after the treatment in autoclave, they'll become mediocre, and after some more treatment with autoclave, that will become awful, only munching the cord without cutting it. So it's almost a finished preparation, but there are some moments that I can correct. For example, apical displacement of the finish line, especially in the buccal side, because this temporary bridge was placed in the appointment when I made the build-ups, and of course the position of the gingival margin changed a little bit. As I said before, on the lateral incisor we decided together with the patient that we will not repeat this rotation of the tooth. We'll create not very logical gingival zenith, but the tooth would be aligned in the dental arch. The crown portion of the tooth would be aligned. Slight polishing. This is the burr 881 red. I just removed maybe remnants of the temporary cement and so on. The temporary bridge was slightly broken from the palatal side in the projection of the lateral incisor. I suspect it was broken by the surgeon as usual, because I don't remember the moments when he was not breaking something. I'm sorry for this lyrical digression. Fortunately he is leaving us soon, and this kind of bad grafting would be the thing of the past in our clinic. Right now I'm placing the retraction cord, sure cord. It is dry cord 00. It's quite bulky in spite of its number 00, it's quite thick. It's not gentle retraction, it's average retraction. It's not minimal retraction. Minimal retraction would be if I would use ultradent 30 and then the top ultradent 00. It will be minimal retraction. But Surecord has a little bit higher thread density and a little bit bigger size, and it's more comfortable during placement. And I think that Ultradent lost its garland as a leader in retraction cords manufacturing, and at least this year. These are my favorite cords right now because of the color, because they don't have memory shape, and because they don't have the piles that is going in all the directions you have to put inside the sulcus. It's okay for the second cord, but the first cord with the piles of thread, it's really a nuisance. Right now we're removing the helium abutments, Astrotech implants, but we see that Dentium screwdriver is quite okay for it. We don't have regional screwdriver from Astrotech. It's not a system that we're working with. You can take notice the Gingival collar is quite poor. It's not very good for the implants in the anterior position. In the position of the tooth 1, 2, the implant is not deep enough. The gingival collar is a little bit thicker, but the position of the gingival margin is not very good. I would call it clumsy surgery. Right now we're placing open tray impression transfers. One of them could not be fit inside the implant. Why I decided not to cut it from the video? Look, inside there is kind of rubbish. It looks like it's dead epithelium. Maybe when the surgeon was unscrewing something and was performing the grafting, so maybe it's kind of flap was inside the shaft, so it became withered and became foul and prevents us from placing the transfer. So we have to irrigate the implant shaft, not only for the antiseptic treatment but also for the placement of the components precisely. We check if there is mobility, everything is good. Right now the system prepared the impression tray. It turned out even like this. You see the implants are placed in the protrusion. Even with a big cut inside the tray, the transfers are not fitting inside the cut window in the impression tray. So off screen I cut a little bit more in the impression tray to make this window wider. Do not make the small holes exactly for the implant transfers, because you'll miss. You have to do this window a little bit wider, to make these holes wider than you need. This is very convenient impression tray. Unfortunately, I forgot its name. We can break out the segments from it, so we can break out several plates from it. And here I had to grind it a little bit more in the buccal direction, so the transfers are positioned in the direction of the handle of the impression tray. This is not a big problem. Don't be afraid of it. The most important you have to do that you will be able to fit it with the impression material precisely. I was using the impression material here that I was trying to finish as soon as possible to leave the space for cartridges for my favorite impression material. That's why I missed it slightly. You'll see it, but it was not big problem. With a blade you can make in the patch some kind of cuts in order that the transfers could go through it, but you don't need to do that. It's not very important. And right now we are performing the impression. We're removing the second retraction cord. We're applying the wash silicone material. It is my favorite Express Ultralight. You can see how it can be easily done. So we cover completely the stamps of the teeth with the wash material, then work with the impression transfers. Then I apply the wash material on the occlusal surface of all the teeth. I decided to make good impression from all the teeth and the dental arch in case I will need maybe additional wax up for some other teeth. And this is the putty material. It's Penta putty. It's something is wrong with it. It sets very quickly. Maybe it was stored in the wrong way, or maybe it was transported in a freezing condition, something like that. Here I'm trying to, with my finger, try to palpate the transfers. I try to palpate it through the putty. Of course you couldn't do this thing on a raw. So it's the material is already set, but 5 minutes didn't pass. So for 5 minutes I couldn't remove the tray, but 3 minutes after the placing of the tray I start to look for the transfers. I always have at my disposal the blade, so we have to try to find it by touch, by bumping with the scalpel to the screw of the impression transfer. I found one. It was very close to the buccal rim. You always suspect where they are, and you will see it also during the assembling of the tray. Then we have to place back the healing abutments with conical connection. For example, for AstroTech, patient might feel some pain during the placement of this component, so that's why I squeeze with my fingers the alveolar ridge. This is the pressure of the liquid in different directions when you screw the conical thing inside the gingiva. You're not pinching anything. This is the pressure of the liquid. So if you pressure with your fingers, the patient might feel less pain. We screw them in. According to my experience, AstroTech implants are not prone to loosening, so I'm not using the tightening, contrary from Nobel implants. At the same time, I removed the temporary crown from the premolar with impression. You can find videos about the work with this premolar and the tooth 2.6 in the library. Then I have to register the bite. There are not so many supporting teeth. On lower jaw, it's only one inclined second molar, and that's it. So I decided to register the bite with a big amount of the silicone material. Everything is set. We remove it from the mouth. Then the temporary bridge we have to reline, because I was performing the apical displacement of the finish line. Also, there is a missing part of the palatal wall on a tooth 2.2, because the patient came with this broken wall. And I repeat again, I'm sure that was done by the oral surgeon, because there was overjet here. The tooth was not in occlusion, so there is no other way to break it, only with a crown remover, for example. So we made the realignment. Everything is good. After this additional preparation, there is always a void between the main material of the crown and the material used for the realignment. Of course, they can be filled with Temp bond or Relax, but it doesn't matter. I decided to make it more secure because it was before the new year. I was in doubt that something can go wrong. She might go to Netherlands and maybe she would be stuck there, like during the lockdown, as it happened in the past. So I decided to make it more secure. Polishing, well, I will show faster than usual because I'm polishing only in the place of the realignment. So before that, we cleaned the temporary bridge from this temporary cement. We sandblasted it, and we used the adhesive Tetric Universal, the adhesive of the 7th generation. Maybe it was slightly over expired. I don't use it in the mouth, but I use it, for example, these kind of indications, for example, restoring of the temporal crowns or repairing of the temporary crowns. We polish everything. Everything is usual. First is straight handpiece and diamond disc in order to create space for the dental papilla. Then border disc on a contouring headpiece, 6000 RPM. Don't be negligent here. You can cut away some important places. If you didn't polish completely, don't be afraid. You can use additional rubber cap and the polishing paste. We plan to fix the new temp restorations 10 days after the impression, well, at least according to my appointments, but I tried to do temporary crowns in the way that they could live longer, just in case. That a good manner, if you assemble the impression tray for the dental technician, I wouldn't recommend to do it if a dental technician can do it properly himself, and if he's working on a distance from you, because if it will be for example, dangling inside the box and pressed by something inside the box, so it can lead to the deformation of the position of the transfer inside the silicone. I can show you how you can assemble if you want to do that. You couldn't do assembling by touching the silicone. You have to touch with one hand. You hold with one hand the analog, and the other hand is holding the screwdriver. Otherwise, you'll spin the impression transfer inside the silicone. Then the temporary crowns are ready. This is heat cured acrylic. If I'm not mistaken, it was Annex then, but it's not so important. Heat cured acrylic is quite rare right now. To my opinion, it's more beautiful. Objectively, it has less problems like debonding of the platforms from the temporary abutments, and it could be easily realigned, contrary from PMMA, with a flow composite if you prepare the surface in a correct manner. So we tried the single crowns. Right now we have to fix the single temporary implant crowns. a slight bleeding. It is related with adherence of the epithelium. Astertech components are very famous for that in a good manner. When we start to place the implant temporary crown in a position of the implant of the implant position tooth 1, I understand that the Dentium screwdriver, which is not original for the Astra, is very thick. There is a legend you can use the screwdriver from the normal barrier, but it was just a legend. It's not true. So we'll use a burr. With the burr, I would widen the access to the screw access channel for the implant. If it will be permanent final crown, I would grind the screwdriver, but for the temporary crown, I felt pity of doing that. The temporary crown is placed. We check the contact points. Everything is good. Technician did his job well. There is no need to correct the contact points, just to have to be sure that it will not create any obstacles for the passive fit. Then I widened the screw access hole until I managed to place the screwdriver. I remind you that for the temporary restoration we use the torque 50 Newton on centimeter, so the screw went deeper, and with its slots the screwdriver could not touch the hex of the screw. So I have to widen the screw access hole a little bit more. That tells us that we will not be able to do the screw retention here for the final restoration, only custom made abutment and cement fixation of the crown. For the implant in the position of the lateral incisor, we can do screw retention easily. The screw access hole is ideally placed in the palatal side here. Right now I'm fixing the crown to the implant in the position of the lateral incisor. Everything is here nice and easy, even in spite of the thicker gingival collar. The patient doesn't feel pain because the helium abutment was a bit wider, so we tighten it gently and slowly. Small ischemia, but for this kind of ischemia is not dangerous for us, so we do the torque until 15 Newton on centimeter till we see the turning point of the ratchet from Alpha Bio. It has an adapter inside for the screwdrivers with a square head, so this ring inside the working part, you can change it from the hex to the octahedral, the small one, where you can place the screwdriver with a square head. Right now the time has come to cement the temporary crowns on the teeth. These crowns are quite free, quite loose, so maybe it was not enough temporary cement here. They decided to add some more. Look at the transparency of the tooth stump. I think I will prep it a little bit more from the buccal side, the tooth 1-1, but not so much because the stump is quite small. It is related to its protrusion position. Then the screw access hole we close with the Teflon tape. The Teflon tape for the temporary restoration we can place not so tightly in order to remove it easier and to place more flowable composite. I understand that it's too much. Ask for the scissors, but there were no scissors in the room. Quite strange, but it happens sometimes. So I tear it with my hands. We fix it with a probe. I try to ramp it. It's not so much. For the final restoration I'll do it much more thoroughly and replace the flowable composite. Then in the same manner for the implant, the position of the lateral incisor. This is intermediate result, so I'm planning in the future to do the soft tissue grafting for the tooth 2-1. Also I'm planning to reline these crowns. They're quite loose, they're quite free. The heat cured acrylic could be easily relined with a flowable composite on the final stages of the treatment. There is no need to rush. We're waiting for the healing of the bone graft on the lower jaw, and so implant integration, so we can relax and work for some time with other teeth. Many teeth are ready for the final restoration. Somewhere there are temporary restorations on upper teeth. We're waiting for the implant integration on the lower jaw. I think there will be no total rehabilitation here. Lower anterior teeth are in good condition. Patient likes them, she doesn't want to change the color. We'll see if we can create the occlusal scheme for the patient that could help us not to do total rehabilitation, and it will be only partial rehabilitation here. Then with a flow composite, layer by layer, I will restore this incisor ledge where I damaged it during the drilling. It was already very thin, but for the wide screwdriver, unfortunately, I removed part of the incisor ledge. Then by that time, when I finished working with the implant crowns, the temporary cement is already set. The more it's set, the more it's solid, it's easier to remove it. It's good when it's not like a door that can be no, it's good when it's rigid. It's easier to remove it. See, it's kind of breakable and crunchy. I received a lot of questions why it's not a PMMA. Well, because I can afford it, because PMMA is worse than heat cured acrylic. Let's be sincere, let's be frank. I can ask you why you are not using acrylic, why you're using PMMA. Of course, the majority of temporary crowns on implants right now, it's PMMA. It's difficult to find the technician who will work with the heat cured acrylic right now. Right now we remove the temporary cement between the teeth. The gingival embrasures are quite wide. I think we will need to change the shape of the crown in the contact areas, in the gingival embrasures, but we have to give possibility to the gingiva to form. So as much as it will grow, this is the way we will create the shape of the final restorations. So then I will just replicate on the analogs the emergence profile of the temporary implant crowns, and we'll take another impression with the same impression transfers, but they will be customized. Then we perform the correction of occlusion. We see right now, because the teeth were created in a more retrusive position by the dental technician, they started to have contacts with the lower teeth. It's not always easily tolerated by the patient. If the patient was living all his life with overjet, and by closing it thinking that it is what required in the textbooks, this is not correct. You have to relate how old is the patient. If the patient is used to this kind of bite, the patient used to move the lower jaw without obstacles from the upper jaw, so we have to find out whether there are complaints about the restriction of the movement of the lower jaw with these new temporary crowns. This is their additional function besides their appearance. So if it's convenience, then I polish with a rubber tip. It's Canada rubber tip, green color. And the picture, how it looks right now, it looks quite decent. Will work, go further on. All the best.